Hello, everyone. It's a great honor for me to be here today to talk about the Living Lab and rural emergency medicine research we've been conducting for the last 10 years at Laval University. My name is Richard Fleet. I'm an emergency physician and clinical health psychologist. I'm a full professor at Laval University and hold the endowed chair in research and innovation in emergency medicine. But our main focus is really rural emergency care. So I want to thank you again for being here. I want to thank you for all that you've been doing in the rural areas, training those cohorts of students and working and improving access to care across the nation. And your work is absolutely essential. And thank you for coming to listening to this talk. Thank you especially for giving me your time. Because as you know, physicians are poor. We're not poor in terms financially necessarily. We're poor in terms of time. We suffer from time poverty. And we're exhausted. According to the Canadian Medical Association, about half of us are suffering from some sort of burnout at this particular time. It's been a challenging time. So even appreciate that you give me this time, especially since you will never get it back. Speaking of time, time flies. And it's already been 10 years or more since I experienced something that has changed the course of my life and also the course of my research career. And it is this experience in a rural setting that is the reason why I'm here today. I'd like to tell you the story. So this is Nelson, British Columbia, southern central British Columbia, a beautiful ski town, temperate climate. It's one of the most beautiful small towns in Canada. Many of you know Nelson. It's quite famous. It's where the movie Roxanne with Steve Martin was filmed. And so I had the chance to work there. This was my first job as a physician, and I became the chair of the emergency department there at a time where they had multiple service cuts. So a newly elected government had closed the surgery service, the inpatient, the ICU, there was closed the inpatient psychiatry unit, there's no CT scan. And so we were left transferring patients, a lot of patients at great distances for their care. And so we felt as physicians that we were not providing optimal care. And we started advocating, going through the regular meetings, but we advocated and participated in multiple committees and political campaigns to try to improve the care. But there's really not much research in this field at that particular time. And so we didn't have much to go on outside of our expert opinion, but also the community's feeling that, you know, things should be better. And they wanted to know what we thought. And so despite advocating, and this article is published in the Canadian Journal of Rural Medicine, despite advocating for all of this, the situation did not improve and got worse over the years. And so, like myself, several physicians felt that they were even insecure for their own health and their family. And we decided to try to take on other positions to ultimately improve the care in this setting, but elsewhere as well. And so this is how I ended up in Université Laval. The position opened again and I took this. But let me tell you about my last shift in Nelson. It's about 4 a.m. This elderly patient who I'd seen before walks in with abdominal pain. I examine her, do a regular basic workup with what we had. And again, we didn't have a CT scan. Performed a bedside ultrasound to realize that she had an abdominal aortic aneurysm, a AAA of 6.5 centimeters. Normally, such a case would go straight to the OR in a vascular surgery, but the closest one was in Kelowna. I called the vascular surgeon immediately. He says, you can send her over. You're very far. It'll be complicated. There's only one plane for the province. No helicopters could evacuate. It's in the middle of the night. So he said, I'll organize it. And in the early morning, we'll fly her out. So I'll go back to the patient and discuss the situation. And she still wants to go ahead with this. Despite her age, she was otherwise healthy. So before the end of my shift, she stops me and says, Dr. Fleet, by the way, if I don't see you again, I wanted to tell you something. Yes? She said, I want to thank you and your colleagues for what you did to advocate for us. This used to be a really good hospital before all of these major cuts. And it's important that you do this. And I understand that many of you are going to leave. And truthfully, I don't blame you at all. So I'm apologetic and, we chat. So I walk around and then she stops me again. Dr. Fleet, And she sits straight in the stretcher, looking me in the eyes. And she says, if I don't see you again, promise me one thing. Continue the fight. I'll get back to that story later, but the Fraser Institute hospital report card ultimately proved us right. This used to be one of the best hospitals in British Columbia. It ended up being the last after the cuts, especially for emergency sensitive conditions. So I took this job that opened up again at Laval University and decided to dedicate my career in rural emergency care, thinking about Nelson, and kept in touch with this community over the years. All of these studies were published before COVID. We found out that there's a significant proportion of the population that lives rurally. And out of the 14 million emergency department visits, 4 million happen in rural hospitals across the country. In certain provinces, half of all emergency departments in that province are in small rural hospitals. So rural emergency departments are important safety nets for the population. And this is something that I didn't know before. My question is, did you know this information as well? So when I started at Université Laval, taking on this position, I had turned down several years to become a rural doctor in Nelson, to spend more time with my family, my young kids. I decided to compare, our team decided to compare Quebec to other provinces, Ontario, British Columbia, and then a random sample of Canadian ERs. There are 300 of those in terms of access to services. So who has as a general surgeon, ICU, what other specialists do you have? And we saw extreme differences between provinces and obviously big differences between rural and urban. So for example, one statistic, only 20% of rural hospitals have a CT scan. Did you know this? Another finding that actually kind of concerned us, especially coming from an urban center, was that less than 15% of rural hospitals actually have a CT scanner, a tool that's actually now basic in the terms of the diagnosis of emergency sensitive conditions. There are 70% of rural hospitals in Quebec do have a CT scan. The system is structured differently. But this is a concerning finding, considering that lots of patients are being transferred for this. Did you know this information? So if you don't have a CT scan, then perhaps you can't treat stroke according to guidelines. Perhaps you can't submit your patient to a CT scan within the first half hour of arrival to the ED with symptoms suggestive of stroke. And this is what we studied across Canada, rural versus urban mortality from stroke. And this paper actually won the best research of the year at the College of Family Physician a few years ago, and I thank them for this. But essentially, the sad situation is that if you have a stroke in a rural hospital, you have a 25% higher 30-day mortality. And this was all over the media, and this was very concerning. Did you know this? So you might be thinking, what are other emergency sensitive conditions? Well, there's very limited databases that are accessible across the nation to look at these conditions easily. But we did have trauma data, good trauma data in the province of Quebec, and looked in this study, retrospective 5-year cohort of about 80,000 patients, and looked that if you have a trauma in a rural area, your mortality is 3 times higher in rural than urban. Did you know this? And so because lots of time is spent in an ambulance or waiting for transfers, in fact, interfacility transfers are a critical piece, and because many hospitals don't have a CT scan, many transfers are just for CT scan. So the College of Family Physicians, the Society of Rural Physicians on May 4th is holding in Ottawa this big meeting looking at transfers. Maybe putting a CT scan is actually going to solve a good part of the transfers. Now you can transfer a patient with a diagnosis and explain that your patient has this and this condition for sure, and you need to get them out faster. And maybe you'll optimize all this transfer process and actually even save costs. So we wrote this editorial, Canadian Journal of Emergency Medicine, a few years ago, advocating that maybe rural hospital should have a CT scan. Did you know about this information? For more than a decade now, more than 50 scientific publications on this subject that we've published, 200 scientific presentations like this one here today, reaching more than 300 people, participating in multiple rule committees, boards, task forces, and associations, conducting media interviews and reports, and publishing whatever information we have on social media. For more than a decade, we've been on this, and you've been working on this as well. But things have not changed that much. Did you know this? Did you know of our research as well? And if you don't, then please do not feel bad, because it takes 17 years for 14% of the research to have an impact on the patient. I guess if you want to be famous, just don't be a rural researcher, because it's hard to reach people who are interested in this type of research. And in fact, when I give conferences in urban academic settings, very few people actually participate in these conferences because we're a small group of people, and research is not that popular at multiple levels, including in the rural setting, because we're far from the academic centers, less experience in this field, not necessarily funding. And this is unfortunate, because research is extremely important. But in any case, 17 years is way too long to see a change from the data to the impact on the patient. It's way too long because people are dying right now, for sure. And even the Society of Rural Physicians of Canada, right, since COVID, has shown that across the nation right now, rural hospitals are closing left and right because of workforce shortages that are extreme all over. So what should we do? Of course, working as we are working on committees, as you are working in your, as deans, vice deans of rural hospitals, campuses, it's important to continue what we are doing. But we had two strategies. We have two strategies recently, and they're inspired by the science of happiness and the science of creativity. Why happiness? It's because we need to get to what makes people tick. So if you can understand why they do what they do, why makes them happy, perhaps you can attract them, perhaps you can make them invest themselves more in this particular rural practice. And of course, in terms of creativity, we don't teach creativity in our medical schools very much. We teach convergent thinking. We give information to our students that's already well digested and screened for exactitude, but we don't teach students to think outside the box. And in fact, in rural settings, we need outside the box thinking. So we are inspired by the Institute of Healthcare Improvement, especially those that started the quadruple aim, now the quintuple aim, the joy and work framework. We're also inspired by what we call design thinking. This mode of thinking that's used in the design business. It's a way of, I guess, operationalizing creativity, the creative thinking extremely well. So what did we do? Well, you know what? Believe it or not, being from Quebec, being in the circus capital of the world, and the Charlevoix region being the birthplace of the Cirque du Soleil, we joined the circus. So seriously, the Quebec scientific in chief launched this contest, this grant proposal, where you could associate and have support for artists, scientists, to try to bring your research at another level, to break the silos of sorts. And we work with the circus industry, the Seven Fingers in particular, to try to improve our knowledge transfer. They're show business. They're in the business of bringing people to their audience, and they're also looking for causes to invest themselves beyond creativity, beyond, I guess, just producing a show. And the Living Lab is really giving power to the people. So what did we do with the circus? So actually, in this study, the circus took this research study, Rural 360, where we went in all rural hospitals, looking at the solutions and the challenges of all rural hospitals in Quebec, interviewed about 200 people. So they took the data of this study and actually created a movie. So I have a postdoc, a PhD student, Julie Teberge, that's comparing the reading of a report, a scientific report, the web conference, like a PowerPoint, to this circus show. Let me show you a teaser of this. So we would love to go and see you, either to show this show virtually or to be in person with this show someday. If we have the means to tour, we would love to show you how this is more important than a standard presentation like I'm doing here today. The other thing is that we decided to give the power to the people. And we started this Living Lab in Charlevoix. So Living Labs are really the bringing together of citizens, decision makers, and healthcare professionals in one small area. For us was Charlevoix, where the Cirque du Soleil was born, in this creative, artistic town, to bring people together and to say, what are the solutions you have to improve the care? And how do we prioritize that? I'd like to show you a 3-minute video on the Living Lab Charlevoix.
On s'est aperçu qu'on avait un peu la même idée. C'est qu'on voulait faire découvrir, de rapprocher en fait la population avec les hôpitaux.
L'énergie qu'on peut avoir dans le niveau du système de santé, comment on peut renouveler notre système et comment on peut mobiliser la population là-dessus.
Ça va éviter les citoyens, en entrant au centre de santé, de pouvoir aller jeter un coup d'œil, rencontrer des gens, connaître aussi ce que fait Living Lab, l'innovation qui est présentée là.
J'ai fait le stage dans la cohorte 6 et j'ai beaucoup aimé ça. Dans le cadre du stage, on m'a confié le projet de présenter mon projet de doctorat qui est un spectacle de cirque sur la recherche de Richard Fleet sur les enjeux de santé en milieu rural.
Fait que les questions portent sur différents sujets. Généralement, c'est sur le leadership, la créativité, l'innovation. Ça porte sur le wellness. Ça porte aussi sur le milieu rural ou la gestion de pandémie. Des fois, on essaie de toucher à tout dans la même conférence. Ça porte aussi un peu sur le background de la personne qui est invitée. Parce que les personnes qui sont invitées, on fait beaucoup de choses pour la société.
J'avais un patient traumatisé dans la salle de réanimation. J'ai appris en radiologie, j'ai dit, amenez votre machine d'écho ici, ça prend une ultrason ici au chevet. Une chose qu'on a peut-être pas tendance à faire quelques années plus tard, quand on a eu quelques bagarres avec les autres spécialistes. Mais comme j'étais tout feu, tout flanc à ce temps-là, je l'ai fait. Et la radiologiste en question a dit, oh, c'est impossible, la machine est trop grande. Et je dis, je sais parfaitement bien que cette chose-là est sur des roulettes. Amenez-moi ça ici parce que le patient est trop instable pour aller chez lui. Et elle l'a fait. Elle est venue, on a fait l'écho, juste là au chevet. Et en effet, le monsieur avait du liquide libre dans l'abdomen, monté tout de suite au bloc. Ça a complètement changé ce qu'on a. Et je lui ai dit ce jour-là, vous savez, un jour, on va faire nos propres échos humains.
Great strength of medicine and the debilitating weakness of medicine is its categorization.
Et donc, pour moi, une pandémie, c'est un phénomène socio-économique et je dis toujours qu'une épidémie commence dans une communauté et se termine dans une communauté. Et donc, il faut que la communauté s'approprie l'épidémie. Et c'est pour ça que je trouve ça intéressant des régions rurales parce qu'elles ont été peu affectées. Donc, c'est une espèce de menace un peu ésotérique, un peu difficile à imaginer. On n'a pas eu les morts par dizaines en région. On n'a pas eu des camions réfrigérants à l'extérieur des hôpitaux ou des centres de longue durée pour personnes âgées. Et donc, c'est important de s'assurer que les communautés s'approprient c'est quoi la COVID-19 puis pourquoi on doit faire quelque chose.
On commence avec le prototypage. Et pour moi, ça, c'est un moment où la créativité, c'est encore plus important. Parce que le prototypage, ce qu'on essaie de faire, c'est de rendre ça le plus, je sais pas, représentatif du problème, des idées qu'on a, mais avec le moins de coûts, avec le moins de temps. On fait ça avec des semaines, peut-être une semaine. On va faire un prototype d'un spectacle dans une semaine. Okay. Qu'est-ce qu'on fait faire? Alors, le testing et le prototypage et le testing, c'est vraiment un cercle qu'on fait en prototype, on teste, on apprend quelque chose, on rend un nouveau prototype, on teste, on apprend quelque chose, on rend nouveau. Puis on utilise cette cercle, puis chaque fois, on rend le prototype un peu plus, je sais pas, robuste en termes de son design, un peu plus comme c'est moins le papier avec un carton, quelque chose comme ça, puis on commence à créer des choses, on commence à bâtir des choses. Mais c'est vraiment pour commencer à faire le moins possible, le plus vite possible. Alors, 5 étapes dans le design thinking, c'est l'empathie, le framing, idéation, le prototypage, puis le testing.
So thank you. So we did publish an early version of, let's say, the prototype of what this could be in the Future Healthcare Journal, the journal of the College of Physicians and Surgeons of England. Why? Because we had been invited to present this by the Neufeld Trust in London a few years ago before COVID, and they actually said we should publish this. And so we went ahead and published this idea. So you could learn way more on Living Labs by Googling this, but there are many books on this subject and articles now. It's a new way of bringing creativity to another level. And it's to be audacious, to work with multiple different people, and to have a high impact rapidly. And this project was also developed during my program, the International Masters of Health Leadership from McGill University, a program founded by Henry Mintzberg, of which Dr. Yu is a graduate, and they participate in the Living Lab. And because of them, we were able to reflect more deeply on this. And this is my final project for this paper. So design thinking, they talked about it in the video. I won't go more in this, but I recommend that you read more on this if you're interested. And this is a new way of thinking developed in the design world, but not much yet in the healthcare field, but it's coming there. So the Living Lab Charlevoix essentially was an idea to bring students, residents, various healthcare professionals at a time where the pandemic was starting. It was launched in February 2020, right before the pandemic. And so we wanted to bring the rural community, said, bring people in, help us out in any which way you can, because we're going to lack people. So we said, we'll bring residents, and the university helped us with this. So we created this rotation that teaches leadership, wellness, innovation, creativity, and rural health. And we're in 2 hospitals in this nice region that's a little bit over an hour from Quebec City. It's university affiliated. It's an attractive place, brand new hospital in Baie-Saint-Paul. So we've had now close to 10 cohorts, various medical specialties, and we do provide this in-depth training. In terms of courses, well, people read a lot of books, separate books and articles, but essentially we invite leaders. I encourage you to go on our website, Living Lab Charlevoix, or on the YouTube channel to see which leaders we've invited. You'll be very surprised to see the people that gave 90 minutes of their time really upfront to talk about their life, their career in a very spontaneous way. So we'll discuss at another time all the different innovations that went through, but those that also failed at certain levels, because failure is actually one of the most rewarding things to learn from. And you can never lose in a Living Lab philosophy because you always learn something, and it brings about this culture. So multiple media reports with the students on the different innovations, and our students participate in all of this for the community. We also created these reflective sessions where I invite the community to think about, various problems in a design thinking fashion. So what's the future of this? Well, actually, we'd like to one day scale and spread this to other areas in Canada. We've started in Quebec, but we'd like to go and see you one day, and we've applied for grants to do just this. So in conclusion, I think what sums it up the best is that if there's 2-tiered medicine in Canada, it's not the rich and the poor, it's the urban versus rural, says former president of the SRPC, John Wooten. I would not be here today if I hadn't lived this experience in Nelson, British Columbia, that has inspired me throughout the years. I went back to Nelson several times, and we presented where we are now, and they're doing well. They have a CT scan, a brand new emergency department. They're affiliated with UBC, and it's become an increasingly attractive place to live and work. And people ask me, what happened to that patient, Rick? Well, on that next day, I was on shift. Actually, that same night, I get a call from the vascular surgeon. It's at 7 at night. I placed a call at 4 or 5 in the morning. He says, Dr. Fleet, the patient just arrived in our hospital. So the planes were canceled and she had to be transported by road ambulance, believe it or not. And he says, as she was wheeled into our hospital, she died. And so we dedicated our research over the years to her and to the rural citizens that actually are faced with suboptimal care. As she asked me, I asked you, please continue the fight. Thank you.